Welcome to prIME Oncology. This is an expert perspective in lung cancer. This is a CME-certified activity in collaboration with the Adario Lung Cancer Foundation. I'm Ravi Salgia, and I'm a professor and chair at the City of Hope, and I'll be talking to you about lung cancer from chaos to precision medicine. I've been at the City of Hope since January 1st, and prior to that, I was at the University of Chicago. My big interest is in lung cancer, and I'll be talking to you about lung cancer in terms of the diagnostics, therapeutics, and ultimately how we've come such a long way to be able to treat our patients with lung cancer. I'll be describing precision medicine, as well as detailing molecular abnormalities, introducing new concepts, especially about fractals and chaos theory, and I'll explain that in a few minutes, and give recent examples of precision medicines, such as EGFR and ALK. So as you all know, the standard of care for lung cancer is very typical for all of us in our clinical practice. For non-small cell lung cancer, as an example for stage 1, we do surgery, sometimes SBRT, potentially adjuvant chemotherapy for stage 1B disease. For stage 2 disease, we do surgery and adjuvant chemotherapy. For stage 3, it's divided and subdivided into A with chemotherapy, radiation therapy, or surgery that is trimodality therapy, or in stage 3B with chemotherapy and radiation therapy if possible. Stage 4 is very important for us, where we do chemotherapy, but we may be able to do radiation therapy based on, let's say, lesions in the brain, or potentially surgery depending on the situation. Small cell lung cancer, which comprises approximately 14 to 15% of all our patient population, you think about in terms of early stage disease with chemotherapy, radiation therapy, and prophylactic cranial irradiation. And also in terms of late stage disease, you think about chemotherapy, potentially thoracic radiation therapy, as well as prophylactic cranial irradiation. Although we've done a lot of therapies and a lot of standard therapies for our lung cancer patients, we haven't really impacted very much so, except for the past decade, we've seen considerable advances made in molecular medicine. I consider myself a molecular oncologist, and I've been doing this for over 25 years now, and really precision medicine has come to fruition for lung cancer. So what is precision medicine? I'd like to describe that a little bit, and that is it's a multifaceted approach to medicine that integrates molecular and clinical research with patient data and outcomes and places the patient at the center of all elements. The precision medicine may include tumor-specific information. The tumor origin is quite certain in most cases. Tumors being broken down into subtypes, and subtypes are fluid with new findings. And tumors usually are heterogeneous. We still have much to learn about intra-tumor variations itself. Precision medicine includes potential useful information on messenger RNA, microRNA, and related aspects of DNA. Precision medicine includes information from other omics. I love the word omics. Being Indian and practicing yoga, we are always doing omics, or omics, and such as genomics, proteomics, metabolomics, epigenomics, and I'll describe them as we go forward. What's been very interesting since I've been practicing for over a quarter of a century is that we no longer think about population as a whole. We tend to individualize therapy. We can use population as a whole to learn things. However, every patient is different. Every person is different. How we treat that person is different. And we really take into account what had happened in the past, that is everybody got chemotherapy, potentially blindly. But now we start thinking about, can you do molecular medicine? Can you do molecular analysis? And then try to come up with the targeted therapeutics or precision medicine itself. And in panel B, what's shown in the past we used to do for clinical trials themselves, looking at efficacy, looking at toxicities. But not only do we want to do that, but we also now want to look at biomarkers. What are the prognostic biomarkers? What are the predictive biomarkers? What are the therapeutic biomarkers themselves? And so for today, at least what we try to do in our clinics, we really try to make sense of a person's lung cancer. One person's lung cancer is not the same as another person's lung cancer. So as patients come to see us, we have to look at the tumor tissues. We have to look at the archival tumor tissues or get fresh biopsies. Then we want to be able to look at the molecular characterizations, and based on the molecular characterization, see how we can do therapeutics. But ultimately, and unfortunately at times, we do have to worry about progressive disease. So what happens when one gets progressive disease? We have to consider repeat biopsies or serial biopsies or liquid biopsies, and then try to figure out what else we can do for resistant mechanisms. I'll give that example for EGFR and ALK, and really it's important for every person as we see. So in the old days, we used to say, non-small cell lung cancer is divided into adenocarcinoma, into squamous cell carcinoma, large cell carcinoma, and then you have small cell lung cancer. But I don't consider lung cancer anymore. I consider that tumor arising within the lung, and it's a subset of a subset of a subset. So when I see a person in my clinic, I usually start off my sentence as an example. A 48-year-old woman who has non-small cell lung cancer with an adenocarcinoma histology and molecular markers show EGFR positivity with an L858R mutation, who has gotten erlotinib therapy and has progressed and now has T790M mutation. That's how I really start my sentence in the clinic. So we've really become subset, subset, subset. So how does one really think about that? And I tend to think about that as what's called a mind map. So those of you who've taken business classes, you understand about mind mapping. And our kids actually in high school are taught about mind mapping. And what a mind mapping is, what our minds go through as we're given a topic. So if I was to be given a topic like California, I would say, Banja Daria Foundation. I would say City of Hope, or I would say UC Davis Hospital. And at the same time, you would think about California in terms of the great wealth of people that exist here. But then you would say California versus Illinois versus Massachusetts. So see how your mind is categorizing all these things? So as we teach our students, as we teach our fellows and our faculty, we start thinking about even cancer and categorizing them as a mind map. So here, for example, is a mind map for adenocarcinoma. We think in terms of colorful ways, and this is a colorful way of thinking about adenocarcinoma, where you can have an immune subset, or you can have an altered pathway subset, or you can have mutations. We'll talk about that much more for EGFR. And you can have translocation, for example, ALK can have translocation, or you can have amplifications. So you see, it has become a lot more complex. When I started my career, it was easy. One would say non-small cell lung cancer, we wouldn't have any histology subclassification of that, and we would just say, let's give chemotherapy with agents such as cisplatin and paclitaxel. But now we really have to subdivide all of these molecular markers to be taking into account what happens to our therapeutics themselves. So as an example, here's one that was published that looked at the molecular subsets in what are called the driver mutations. So one can look at EGFR or KRAS or MET or RET or ROS1. And these are all important, and as we go forward, we have to be able to look at that very carefully for our patient population. One of the things that I always say is that it has to be individualized. All these maps are great, all these pie charts are great, but you have to take the population into account here. Asians have a different genotype, phenotype as an example, as compared to African Americans, as compared to European Caucasians, and we have to be able to really look at the molecular characteristics that way as well. And then adenocarcinoma is different, as example, considering squamous cell carcinoma. So you can really appreciate that the immune subset is different. You can also appreciate that the altered pathways are different. And the genomic profiling is different for molecular as well as copy number alterations themselves. So it has become quite a complex and a challenging issue for us. But I think as we tend to figure out how we can come up with better therapeutics, this will become much more simpler as we go forward for our therapeutics. So here's a paper that all of us published several years ago to look at, for example, adenocarcinoma versus squamous cell carcinoma versus small cell lung cancer, some of the mutations that we're looking at it in the clinic, but there are a lot more mutations coming out now, and then how one can do therapeutics based on that as well. So as we think about all of these genetic alterations that can occur, and as we think about mechanisms of metastasis that occurs, lung cancer, we worry a lot about mechanisms of metastasis or metastatic disease, let's say to the bones or to the brain or to the adrenal glands. How do we make sense of that? How do we put it all together? So I actually used to be a mathematician. When I was a teenager, I published a lot on basic complex analysis. So that's, you remember in your high school days, you learned, or in college, you learned about I, the imaginary number. So I is the square root of -1. So when I was a teenager, I actually lived in the complex plane, basically. And I thought a lot about geometry. And then I gave it up because I actually loved taking care of patients, and I come from a family of physicians, and we really take pride in the fact that we want to be able to take great care of patients. But then a thought occurred to me, and then our whole group several years ago, to say, we should be studying the lung itself and how cancer arises, and then ultimately come back to therapeutics. So as you know, the lung is a large organ within the thoracic cavity, and the surface area of a lung is approximately the size of a tennis court. So how can you have a small thorax containing such a large surface area? So nature has provided us with some hints that we can take advantage of. So taking into account the geometry that we had learned in the basic complex plane, we started thinking about fractals. So I'll explain what a fractal is. So fractal is a mathematical set or concrete object that is irregular or fragmented at all scales. As you can appreciate, what's that cast of human airways, that's a branching pattern, right? You go from trachea to the bronchi, all the way to the bronchioles to the alveoli. So you can see it's called a self-iterative function. It's patterning itself. So the way I think about the bronchus and the lung developing in the human body is how I look at Lakeshore Drive in the winter in Chicago. So imagine yourself being transported to Chicago currently. It is cold, but at the same time, think about all those trees that you're seeing on Lakeshore. And in Lakeshore Drive, all the trees are very barren and they have no leaves. Turn those trees upside down and you have a bronchial tree. So taking into account what happens in nature is really what's happening in lung development. And so what is really important, Benoit Mandelbrot in the 1960s actually described this, is that we no longer live in single-digit dimensions. So we're not in Euclidean dimensions. We're in this room here, for example, we're in a three-dimensional world, and we have bricks and mortars, and we have rectangles and squares. But actually, nature doesn't do this. Nature creates oceans. Nature creates trees. Nature creates all of these elements, and those are actually fractional dimensions. They can't be measured as dimension of 1, 2, and 3, but they can be measured as fractional dimensions. So how do you measure that? You actually measure that by looking at self-similarity function. And so here's one example before I go to the lung. So on the top is the exact self-similarity. That's called a Sierpinski gasket. And then as you go down various dimensions, it has the same self-similarity. But then you also know that from fern, as an example. So when we were growing up as kids, you would be amazed at looking at a fern because, the tree looked like the leaves. And so how is that possible? It's really possible in an iterative function. And at the same time, you can have a statistical self-similarity. So this is an example of the Great Britain coast. And as you go down on the Great Britain coast that one can see, you can actually never measure it, right? How do you measure a coast? But you can actually measure its fractional dimension. So we took advantage of that. Then we went back and tried to learn what is it that's going on within the lung. And so it turns out that the structure of the lung is fractal. The tree-like structure of the lung can be constructed by simple recursive branching rules, right? Trachea going into the bronchi, going into the bronchioles, going into the alveoli. But at the same time, you need this. And you need this because you have a maximum surface area with minimal supportive tissue. You also have alveolar placement along the airway combined with decreasing airway diameter, and airway permeability allow for efficient gas exchange all the way to the terminal alveolar sac. And then it also allows for efficient matching of the airways and vascular trees. Now I think you appreciate this iterative function, this branching rule for lung, and ultimately the lung cancer hijacks this and then creates its own geometry. And the way it does that is by the genomic alterations. But before I show you that, it turns out fractal is actually a sub-branch of what's called chaos theory. And this is really deterministic chaos, and this actually I'll explain in a few minutes. But let's go through a game. Let's play a game together. And this is better in Las Vegas, but I'll play it anyway. And suppose you have a triangle, and you figure out a dot in the middle. That's your red dot in the middle. And on the triangle, you label the vertices as 1, 2, 3, 4, and 5, 6. Now suppose you have a dice, and the dice is labeled 1, 2, 3, 4, 5, 6. And then you roll the dice. Let's say your first roll is a 3, so you go halfway from the center point to a 3. With me so far? Then you roll at, let's say, a 2, so you go from that to a 2 halfway. Then you roll again, let's say you roll a 5, so you go to 5 halfway. So what would happen if you did this till infinity? And any predictions? Majority of us would predict, indeed, that the whole triangle will be filled. But if I can roll the video. This is known as a Sierpinski triangle. So we did this iteration function on computer simulations, and it really turns out to be a fractal. So from the deterministic chaos game, we determined that we had a dice, it was constrained to 6 values, and then we did the triangle. So if you look at it at a much higher level, and I think I have a large imagination, you can even pretend that these are little alveoli. So you can truly create lungs via deterministic chaos and or fractals. And fractals are important because some of you have watched the movie Frozen, and there's a song that says Frozen Fractals. And for the aficionados in this room, and you can go back to YouTube or see the Frozen fractals are snowflakes. They're self-iterative functions which are symmetrical. And so this really comes under the chaos game and deterministic chaos. And you always think of chaos, for example, I think of chaos before I started all this a long time ago as like my kid spilling milk. That's chaos. But in mathematical terms, it's really deterministic chaos. So the weather pattern from today predicts tomorrow. So that's deterministic chaos. But it's really chaotic if you're going to determine the weather pattern in a month. But you can still do it. You might be right, you might be wrong, but at least you can do it. So chaos appears to be random, but it's not. And chaos differs from randomness in that chaotic systems are purely deterministic. At the same time, chaotic systems are especially sensitive to initial conditions. So tomorrow's weather depends on today's weather. So if you can take it from that, you can really do simulations of the chaotic system. But what relevance does that have to genetic alterations? What relevance does that have to lung cancer, or actually any cancer, or any diseases, because it's very relevant to that. So the chaos game that I just played, we started to play that for DNA. So instead of having a triangle, we built this plane. So look at the CG are these bases of DNA, and AT. So CG is what's known as the abscissa, that's the x-axis, or AT is the ordinate, or the y-axis, or the vertical axis. So imagine that sometimes it's in a complex plane, so AT is the imaginary plane, and the CG is the real plane, or real line. And we define some rules. That is to say, the starting point, if you move up, then you have an A, move down, T, move right, G, move left, C. And then we did that for various DNA molecules and various chromosomal structures themselves. And an interesting thing happened. As you can appreciate here, in the green is EML4, that's on chromosome 2p. And in the red is ALK, that's also on chromosome 2p. But when you have that translocation, you can see that in orange, completely different structure. So it really forms a fractal globule within the chromosome. So now you can actually appreciate how the cancer and the genomic alterations have hijacked the cell and then ultimately made it geometrically very unique, but then be able to reproduce much faster. But how relevant is that for not only DNA, but can you go to organelles? I actually presented this in South Africa about a year ago for mitochondrial functionality, and mitochondria tend to have a lattice-like network, and you can do the same thing for fractal dimensions for the mitochondria. But then can you look at the cells and the tumor tissues themselves? So for example, we took small cell lung cancer and magnified it at several fold. And then you can see 2x, 5x, 10x, 20x, 40x. and then looked at the fractional dimension or fractal dimensions, but then we also looked at what's called lacunarity, or the texture. How solid was the tumor? So as you can appreciate, on the ordinate is the lacunarity, on the abscissa is the fractal dimension, and normal cells, which are pink here, that is the normal lung, is completely different than tumors. And the tumors have a very solid, compact texture, so that's opposite of lacunarity, and at the same time, they have a very high fractional dimension. So ultimately, one can envision that this is how the cancer cells develop within the bronchial tree, and then ultimately divide, take over the geometry of the lung, and then go on to metastasize in a much faster way. And so what we are studying currently at this point is determining the fractional changes and the fractal dimensional changes with the genetic changes that can occur. We want to determine the relevance of cellular changes, the genotypic to phenotypic, determine the behavior of cellular clusters, analyze the relative growth and projections, analyze the mechanisms of metastasis, and ultimately determine the prognostic, predictive, and therapeutic signatures. So you can imagine this is a whole new way of thinking about geometry, lung cancer, ultimately therapeutics for lung cancer, but then coming back with biomarkers as well. So is that relevant for us as we go forward? I think so, and this is really a work in progress. We've just started this about 3 years ago or so, and we're really looking at it from the perspective of all aspects, be it at the cellular level, be it at the tissue level, be it at the metastatic level, and then ultimately at the therapeutic level. But then I'm actually a molecular oncologist. I consider myself one. And what I think about it is, what are these molecules and how do we come back with therapeutics themselves? So we think about, for example, if this is a cancer cell, you think about, let's say, 1, 2, 3, 4, 5, 6 that's labeled there. At the cell surface, you have the receptor tyrosine kinases, such as EGFR or ALK or EPH receptors. And then you have signal transduction pathways, which are quite important, such as the RAS pathway or BRAF pathway. You can also look at tumor-associated antigens, such as gangliosides or PD-1, PD-L1. You can look at the mitochondria, cellular organelles, which could be abnormal that you can therapeutically target. You can look at cell survival pathways or extracellular matrix or angiogenic pathway. So one of the pathways that many people have looked at for over actually 2 decades now, but the realities are many mutations have been identified for EGFR, which are potentially therapeutically important. So I'll summarize 10 years worth of data here, and this really came from many investigators throughout the world. And to be able to say that you can have mutations of EGFR, and on the top is the EGFR itself and the various exons, and you have majority of the mutations in the tyrosine kinase domain for our patients with lung cancer. And the most common mutations are L858R, as you can see, approximately 40%, or exon 19 deletions, about 45%. And these are very exquisitely sensitive in vitro, in vivo, that is with cell lines, with animal modeling, as well as with our patients as well. And so we know there are 3 drugs that have been approved here in the United States. There's a long history for this. Initially, gefitinib was used, but then it has come back. At the same time, erlotinib, and of course, afatinib. But selection should not be made on clinical grounds. It should be made on molecular grounds. We should be testing everyone for molecular abnormalities. And that's really important as we go forward. That has become standard operating procedure in our clinics. It's no longer acceptable for us that, oh, I didn't do this molecular markers. It is so crucial that we do the molecular markers for our patients. At the same time, as you can think about even in Asian populations, 40% of highly selected patients have wild-type EGFR. And EGFR inhibitors should not be selected as kinder and gentler treatment for elderly or the infirm. You know, EGFR therapeutics can cause severe rashes. It can cause severe diarrhea. In certain patients, you can have severe interstitial lung disease. You can have abnormalities of the liver functions or kidney function. So you do have to monitor patients very carefully. At the same time, there are several mechanisms of EGFR inhibitor resistance that are currently being pursued rigorously. You all know a lot more about erlotinib, afatinib, gefitinib. We'll have a case discussion at the end. But we are seeing as patients go further and further with all of these therapeutics, development of resistance. Resistance is really a whole topic unto itself. And it depends on what do you feel, what do you get resistance to? Do you get resistance to radiation? Do you get resistance to chemotherapeutic? Do you get resistance to small molecule inhibitors, antibodies? But we start thinking about, in the flow chart here, a primary resistance versus acquired resistance. We think a lot about acquired resistance, and then for that, we have to really be able to do biopsies for our patients. I'll come back to the case discussion a little bit later, but it is very important as resistance develops, as progression occurs, that we rethink about biopsies for our patients and or liquid biopsies. Liquid biopsies are a little bit new to us in terms of our diagnostics, but they are becoming quite important as well. So what about resistance to EGFR inhibition? So such as, let's say, erlotinib, gefitinib, or afatinib. Majority of mutations that can occur are within the EGFR domain. And that's really the T790M that some of you have heard about. But then you can have other mutations as well. So you can have MET amplification as an example. You can have other mutations. Every once in a while, patients who get erlotinib may develop florid disease after a while, 5 years out, 10 years out, even with metastatic disease. And you have to think about histological changes. So it's been described in the literature, and we've seen this, as that patients transform from adenocarcinoma to small cell lung cancer. We've even seen sarcomatoid tumors. We've even seen squamous cell carcinomas. So all this transformation has to be taken into account as well. But it's really the T790M that has really come to fruition, and FDA approval as well. But as we think about EGFR resistance, and this is TKIs, the tyrosine kinase inhibitors, you can think about EGFR pathways, RAS-RAF pathway, or you can think about HER2, HER3 pathway, or the MET pathway. And we've been involved with the MET pathway for over 17 years now in our laboratory as well. I won't talk a lot about that, but really to be able to say that that's another therapeutic target that's coming to fruition as well. So for third-generation mutant EGFR TKIs, you have to start thinking about what are these inhibitors for T790M. So really the two drugs that are talked about mostly at this point is the CO1686, the Clovis compound, or the AZD9291, the AstraZeneca compound. And again, I have no conflicts of interest. I'm not getting paid by anyone, so I'm trying to give this in a very balanced way. But what's very interesting is that if you look at the rosalitinib data, that is the Clovis compound, the 1686, here's the data that was presented by Lecia Sequist and her colleagues. You can really appreciate in this waterfall plot that even in these relapse refractory patients with the T790M mutation, there's dramatic responses, and these are sustained responses that one can see. At the same time, this has not become approved yet, but the other drug that was approved is the osimertinib, and that was presented by Dr. Yanni and colleagues. And both of these papers were back-to-back in the New England Journal of Medicine, and you can refer to those. But clearly that there's dramatic responses that one can see and durable responses that one can see. And it's very important to realize that we have other therapeutics that are being developed and that will come to fruition very quickly, and hopefully for sustainable responses themselves. So as we think about EGFR, EGFR was one of the first targets that we identified potentially in non-small cell lung cancer, but we were very used to that in BCR-ABL world because in chronic myelogenous leukemia, BCR-ABL is translocated, and I used to work on that a long time ago, so that was 25 years ago, which is the Philadelphia chromosome. That's the translocation between chromosome 922. So we learned a lot from heme malignancies, especially leukemias, but I strongly believe that we've come a long way, and hopefully we'll beat the leukemias, we'll beat the breast cancer, we'll beat the colon cancer, and we'll really have attained a huge successful rate for our patients with lung cancer. So as a second example is ALK inhibition in terms of precision medicine. And so initially in 2005, as I was saying, we had worked on MET receptor tyrosine kinase for a long time. We had designed with other colleagues this MET inhibitor, which was known as crizotinib. And in the old days, it was known as PF-0234-1066. And the only reason why I remember that is it's because 1066 is the Battle of Hastings. And so at least that's the one I do remember. But then in 2007, Mano and Soda and colleagues really published a seminal paper. And then as we talked with our colleagues from the University of Chicago, where I was previously, with our colleagues at Mass General Hospital with Dr. Iafredi and colleagues, as well as the colleagues from University of Colorado with Dr. Kamich, it came to the realization, indeed, that there's nice inhibition of EML4 ALK with crizotinib. And so some data that we had previously published, so for example, the Christensen paper in 2005, we knew that there was nice inhibition of crizotinib in vitro in terms of its kinase activity with MET, but also with ALK, RS1, RON, and RON is a receptor tyrosine kinase family member of MET itself, and then of course NTRK1 and 2 and 3 and so forth. But then taking that into consideration, a phase 1 clinical trial, we expanded that not only to the MET-treated patients, but to ALK-treated patients. And this treatment with crizotinib was a phase 1 trial, and dramatically, and I had never seen that in my career at that time, for a phase 1 patient population for non-small cell lung cancer, seeing an overall response rate of 57%. Very interesting and very important. And disease control rate at 8 weeks of 87%. The PFS probability of 6 months at 72%. And crizotinib was incredibly well tolerated. The most frequent adverse events were mild and moderate GI events and mild visual disturbances. Here's the curve that Dr. Kamich and all of us published, and this is the progression-free survival. And you can really appreciate that the median PFS was 10 months for patients who had been relapsed refractory, multiple lines of chemotherapeutics getting crizotinib. So this was really a huge breakthrough. But at the same time, while we were giving crizotinib to our patients, we noticed a certain subset of patients with toxicity. I worry a lot about toxicity. Our patients worry a lot about toxicities, and patients' family worry about toxicity because they have to be able to take care of the patients. We were noticing that in young women, there was like intractable nausea and vomiting. At the same time, in young men, we were seeing like incredible fatigue. So one day I was walking through the hallway, and Dr. Rob Sargis is an endocrinologist, and I was telling Rob, you know, this is very interesting that I'm seeing some very young women who almost have this hyperemesis gravidarum. You know, when you're pregnant and you have this intractable nausea and vomiting, patients were undergoing this, and we couldn't figure out why. And at the same time, you had this fatigue that was important for men. And so we started to look at actually the endocrinopathies that can occur. So in male patients, there was hypogonadism that was detected. In female patients, there was hypogonadism that was detected. But then Rob and I were able to show that there was hypocalcemia, hyperprolactinemia, elevated IGF-1. This had to do with the crizotinib effects, and we really have to be cautious. And so not all drugs are great, right? Majority of drugs that we develop are great, but we have to worry about toxicities. And we really have to be able to manage those toxicities themselves. But coming back to the approval for crizotinib, it was a very fast approval for stage 4 with first line and beyond as well, as you all know at this moment in time. One of the other things that I realized, and we started working together with the whole team, is to be able to say, you know, we have all this fundamental knowledge about translocations, mutations, but what do you do with that? What kind of therapeutics are available? And so we started partnering up with this company called Collaborex. I have no vested interest in them. This was our academic exercise with them, and we have an editorial team. And Marty Tenenbaum started that initially, and we worked with him very closely to be able to say that is it possible for our healthcare providers and for our patients and their families throughout the world that they could have access to us in a very simplistic app. So this app was developed to be able to say, if you have a mutation, what are the possibilities? So let's go through one exercise. And I apologize for my picture. I need to lose weight in that one. But at the same time, what is important is that we work together as a team to come up with these molecular markers and then be able to say what are the therapeutics available. So let's pretend we have a stage 4 patient with an adenocarcinoma, metastases to the liver and bone, ALK positive, EGFR wild type, KRAS wild type, and so forth. But then what do you do? So we give a suggestion. Again, take it with a grain of salt, right? It's very important for patients and their physicians to talk together, but also have that expertise available. Then we give you that level of evidence to be able to say, consider crizotinib or ceritinib. But then the most important thing for us too is what happens if you want to do clinical trials? Are there things for resistant mechanisms? Can you look at these clinical trials? So if you click on this app, and this app is available for the mobile phone as well, and what you can do is that you can really see that these are various therapeutics that are available for our patients. And even if we don't have them at the City of Hope, we might have them somewhere else. So we give you the link to be able to contact that person individually and so forth. I think these are important tools. Many tools are being developed, but at the same time, this was one of the original tools that got developed. So one of the things we worry about, what happens when crizotinib fails? And you really have to think about it the same way as EGFR. Biopsy, biopsy, biopsy. Liquid biopsy, liquid biopsy, liquid biopsy. Without those biopsies, I don't think I can do anything. We're not magicians, right? So we have to be able to know what does it look like under the microscope, what does it look like molecularly, and put together the whole picture radiologically, as well as in terms of physical exam, as well as the whole multidisciplinary group that gets together. And that's so important to have a multidisciplinary group, as well as tumor boards, to be able to talk about our patients and come up with the best therapeutic itself. So again, you can think about ALK inhibition in terms of amplification of the target kinase, mutations of the target kinase, bypass signaling as well. And again, this is not meant to be complex, but it is becoming complex. So you can have mutations in the tyrosine kinase domain, but you can have transformation into other genetic alterations themselves. And so one can look at potential strategies to overcome these. Again, very similar to that for EGFR, but different. So you have to think about this molecule rather than EGFR itself. And then so you can think about second-generation ALK inhibitors for patients. You can think about ALK inhibitors plus other inhibitors, chemotherapies or immunotherapies or HSP90 inhibitors, or looking at the bypass tracks. What are important? Did the bypass go through IGF-1R or EGFR or KIT or MET and so forth? And realistically, based on this, many companies have developed these drugs. Many investigators have really pioneered this. And just to give one example in the context of alectinib, I'll give that, and Ignatius Wu presented that, as well as Shirishka Gill and other colleagues have presented that. But ceritinib, as you know, is already approved, as well as alectinib is approved. But there are more drugs that are coming to fruition. So at least, for example, in this one for alectinib, and Ignatius was kind enough to share these slides with me, and that is to say that these are waterfall plots to be able to show that indeed in crizotinib-resistant patient population, alectinib is effective. At the same time, you have more penetration. So some of the drugs may not penetrate the blood-brain barrier to go into brain metastases. So what do you do then? So alectinib does tend to present itself into the brain, so you have effectiveness as well for CNS metastases. But then again, right, the longer our patients go, the more happy we are. I love to see everybody in our clinics as long-term survivors, but always worry about resistance too. So can we be on top of these resistant mechanisms? Can we learn from our colleagues from heme malignancies, as well as breast cancer and colon cancer world, to say, can we do in vitro, in vivo types of testing that is in the laboratory? And this is one example that was published in Cell as an example, where they were able to look at resistant mechanisms, and that's actually exhibited here, and how you can overcome that through the various pathways themselves. But then these slides are from Dr. Christine Lovely. She just actually presented that at the lung conference here in Santa Monica. And what she was able to do was to summarize this for various drugs and various mutations that can occur. But just to give an example of how intense this can be and how intense our decision-making can be, if you look at that L1198F, it's sensitive to crizotinib, resistant to alectinib, resistant to brigatinib, resistant to ceritinib, resistant to lorlatinib. And so you can imagine how much time and effort it takes to develop all this preclinically and clinically, but then how great it is if we identified this for one of our patients and then we can make that selection. So truly, medicine has come to fruition with precision oncology. So this is your moonshot, right, for lung cancer. And I'm like so excited by this because I've been doing this for over 25 years. We've cloned a lot of genes, but now it's really coming to fruition as well. And so here's one example, right? There are several papers that have been published for in vitro activity for the various drugs, as can be seen, for example, there you see alectinib, crizotinib, ceritinib, and other compounds, and then looking at the various mutations. Imagine how much time and effort it takes. And this is really my plug for doing research and funding research. And because without this, we would have never known how effective our therapeutics would be for our patients, what kind of toxicities would develop for our patients. But then this also reminds us in terms of what we've always done. When I was a medical student and intern, and Christine Lovely really presented this nicely, we had the Stanford antimicrobial therapy book that we would carry around in our pocket. So those of you who've gone to medical school and have gone to internship, this was like our favorite book to carry around so we would know which bacteria and what antibiotic to treat. I think we'll have to do the same thing here for all of our patients, or develop apps that becomes available immediately in the clinic for all of our providers as well. So it's been really a pleasure, but I'm going to actually conclude it here, is to be able to say that precision medicine is leading us toward better individualized care of patients. Fractal analysis may be a useful way to determine prognostic and predictive signature for cancer and therapeutics. EGFR and ALK are now standard of care for lung cancer, and we need to determine how to integrate molecular profiling and traditional therapies. And I do thank you for being here. At the same time, I'll also discuss a case. But at the same time, I'm so excited to be at the City of Hope since January, so this is a plug for our team. I think I represent really a reporter for our team. The whole team really takes pride in taking great care of our patients, going behind the scenes doing research, and then bringing more clinical trials and thinking about toxicities and so forth. So here's our whole team here. And at the same time, I wanted to thank you for inviting me, but I'll actually talk about a clinical scenario if that's okay. And so this clinical scenario is a case study as an example, and that is that what treatment would you recommend for a 41-year-old otherwise healthy woman, never a smoker, who's diagnosed with symptomatic EGFR mutation, exon 19 deletion, with stage 4 lung adenocarcinoma, FDG avidity in left upper lobe, left hilum, ipsilateral mediastinal lymph nodes, left pleura, and adrenal metastases. Her performance status is ECOG 0. So would you choose 1, first-generation TKI, erlotinib or gefitinib, 2, second-generation TKI, for example, afatinib, 3, erlotinib and bevacizumab, 4, chemotherapy followed with erlotinib, 5, third-generation TKI, or 6, clinical trial? So please vote now, and I'll discuss the answers with you. And so the answer is really complex, right? For me, having grown up in a system where we only gave cisplatin and paclitaxel, or even we had these regimens called ICE, ifosfamide, carboplatin, etoposide, for our lung cancer patients, we have come a long way, as Dr. Skaran would say, my mentor at the Farber. And so what we know is that we always have to consider clinical trials first. Really, if we're going to learn anything, we are going to be able to say, are there things that we're doing better than what exists today for tomorrow, for ourselves for today, but also for patients for tomorrow. But at the same time, if you have an exon 19 deletion, afatinib is very reasonable. You can also consider erlotinib. You can also consider gefitinib. Those are all reasonable options. And then there's evidence in the literature now as well, and there are clinical trials going on. Erlotinib and bevacizumab may be good enough as well. Sometimes, and every once in a while, you do give chemotherapy for patients. If it's really large burden of disease, you can't really wait for approval to get for your erlotinib. You can't wait for 2 to 4 weeks for that to come to your doorsteps, and you have to do something. Chemotherapy is not unreasonable, followed with erlotinib or other TKIs. A third-generation TKI I usually don't use in my clinical practice. But then as a follow-up, the patient started afatinib, and she tolerated that well. And after 8 weeks, she was asymptomatic, and imaging evaluation confirmed partial response. She was in remission for about 11 months when follow-up imaging showed slight progression of the primary tumor in the left hilum and mediastinal lymph nodes, and 2 lesions in the liver of 3 centimeters in size. Patient has occasional cough, but no other symptom of disease. Her PS is 0. Excuse me. What would you recommend now? Number 1, rebiopsy, potentially also a liquid biopsy, molecular markers and histology, and if T790M mutation, a third-generation TKI. Continuafatinib and close observation, as number 2 said. Number 3, continuafatinib and local regional radiotherapy, chemotherapy, clinical trial. Again, clinical trial is very important for all of us, but you have to know what you're doing, right? So suppose you got transformation into a small cell lung cancer. The therapy is going to be different. So I think a rebiopsy is very important. Molecular markers are important. T790 mutation, if that's identified, you can think about already drugs that are approved for third-generation TKI, or you can think about clinical trial based on this. But at the same time, this is where your multidisciplinary team is very important. You have to really see your patient. You have to evaluate your patients. You have to talk about your patients. Talk about in front of them and behind them, right? Come up with a consensus. And if there's no consensus, talk to your friends and talk to your colleagues, right? We have friends all over the world, and it's easy to contact them by cell phone or by email. And it is really important, and then you can consider these other options at the same time. So again, thank you so much for coming to this event, and really want to thank Bani Adario Foundation. But at the same time, now we'll go to the shared decision-making in non-small cell lung cancer. Will you introduce yourself?
My name's Elizabeth Lacasia. I was diagnosed in 2007 with, actually not quite sure which stage at that point because they had a hard time defining it. I ended up having bronchoalveolar carcinoma, or as they defined at that time. I had surgery, and about a year later it came back and was spread all throughout my lungs. So I've gone through a number of different courses of treatments, including several surgeries and a number of different types of combinations of more generalized chemotherapies, as well as a number of targeted therapies. I initially had a genomic testing done, and I came up as wild type. About 2 years ago, I was retested after I responded. I was being treated with Alimta and Tarceva and had about 4 years of complete response. And at that point, they retested my genomic testing, and it was more comprehensive. It wasn't just ALK or EGFR. They found out that I had ROS1. So after we found that out, obviously, I went on crizotinib. And I've been on Xalkori for over a year now, and I'm no evidence of disease, NED at this point.
Great, congratulations.
Thank you.
So just to introduce myself, my name is Ravi Salgia, and I'm at the City of Hope, and I'm a medical oncologist. And my specialty is really lung cancer. I do thoracic malignancies, and I've been doing this for a long time. So I was in Boston first, then Chicago, and now here in California. And so it's very lovely to hear that you're fighting this battle and you're winning. And it's great. Will you describe? In 2007, you got surgery. You also got chemotherapy at some point as well. And so how did you feel when you got all these?
Well, at that point, actually, I was in biotech, and I was actually, my specialty was in oncology. And so when I was diagnosed, I was scared to death, because when I went and started reading information, they basically said surgery was the only option at that point, and my initial treatment was surgery only, and I did not have any follow-up. I had a lower left lobe removal, and I had a tumor that was approximately the size of a ping pong ball. I wasn't followed and I did not see an oncologist at that point. And I was followed by the surgeon, and then about 9 months later, I started having the symptoms again of coughing, and they realized that they found out after doing another scan that it had spread throughout my lungs.
Mm-hmm. And you know, this is what we used to call the bronchoalveolar cell carcinoma, and it's what's called a lipidic pattern. It really just crawls along the bronchial walls and so forth, so you cough a lot. Mm-hmm. Sometimes you produce a lot of sputum. Mm-hmm. So were they able to manage your symptoms?
During that period of time, or afterwards, when I started going into more of the chemotherapy? Yeah. Actually, once I was under treatment and it worked fairly well, the coughing really subsided a lot. Actually, the whole reason why I had gone to another number of doctors, and they didn't know that it was lung cancer because I was a runner, no history, you know, extremely healthy, and they just said it's allergies, it's acid reflux, and these sort of things. But by the time I was diagnosed, I had to prop myself up because I was coughing so much at night. But once I'm under well controlled, I have very little coughing. And I assume it's because of the disease itself, the damage. I have some asthma, probable very mild COPD, and they say because of my disease, they don't understand why, but they say that I have a little emphysema. So I have a pulmonologist that I see, and she helps me manage my symptoms quite well by using inhalers.
Mm-hmm.
And there's also reducing the inflammation, which is another reason why she strongly suggests using the inhalers.
I'll go back in time a little bit, and then we'll come back to today, if that's okay.
Oh, sure, of course.
And so going back in time, how did you feel from 2007 until your recent diagnosis of the repeat molecular markers? Let's get up to that point. How did you feel? How did your family feel about all the therapies you had and all this? You know, whenever we do see patients, a lot of patients have so much trepidation, so many fears. And then families too. What am I going to do? How am I going to do? What's going to happen to my spouse? What's going to happen to my parents, my kids, whomever, right? My nephews, my nieces.
Your health care coverage, everything.
Yeah.
Because at that point they had the cap on it. It was terrifying. My husband was afraid. I was afraid. They really basically treated me with standard of care at that time. And you know the statistics for that are for 5 years, survival is abysmal. And being a daughter of a physician as well as being in biotech, I wanted someone who was willing to go beyond and take more of a risk with me to pursue something that was more promising. And so when I started being treated with standard of care, it was very tough because obviously you start having the side effects of more generalized chemotherapy, and my quality of life was very difficult. And it was basically my whole existence was really just trying to stay healthy and manage the effects of the drug and trying to find some semblance of a quality of life. I had been married 2 years before I had been diagnosed. And so, you know, all the concerns involved with that and trying to go back to work and, you know, pay bills and worry about, oh my God, how much is this surgery going to cost and the implications of that, and you know, let alone really coming to the realization of being a snow skier and a volleyball, rollerblading, and having an active life is no longer part of the equation, let alone just being able to walk around the block a couple times without being out of breath. So it really hits your life to the core.
Yeah. Did you have enough support for yourself? Like your husband, you had married 2 years prior. That's always important.
It is. It's
family.
difficult because some people, they're so afraid of losing you that they sometimes withdraw. And so there's a real element of an emotional effect as well. And here my husband is, you know, trying to worry about finances and paying for this and taking care of me and going to doctor appointments as well as holding down a job when I could no longer, you know, I'm retired at this point because of my condition. And so there's so many aspects of let alone trying to hold my hand and being there for me emotionally. It's a tremendous burden to ask of a spouse, let alone a family. And it's very difficult on your parents because my father said, I never thought in a million years that you'd possibly die before I did. And so there's a tremendous amount of complexity with something like this, let alone going through, really, it's like a death in a way because you're losing your quality of life. And so you're going through all the denial and all the different phases of loss. And you're trying to hold it together. And ironically, sometimes you're trying to hold it together for the people around you because they're also suffering all these things. So having a diagnosis like this and such a serious disease is a tremendous undertaking, and it affects people in all aspects of their lives.
Yeah, it's very tough. You know, I've been taking care of patients, and I take care of a lot of young patients. And, you know, we worry about the social stigma, too. You know, when I was at Hopkins, so I was an intern and resident at Hopkins, we took great pride in taking care of our HIV-positive AIDS patients. Mm-hmm. And there was, at that time, this was 1987 to 1990, a huge social stigma, right, in terms of how one got AIDS and so forth. But we really didn't care. right? We took great pride in taking care of our patients, but then there was this huge social upheaval where, let's say, Elizabeth Taylor would get up and say we need to have great therapies for HIV-positive patients. But for lung cancer, we really knew that there's important things, and people, and majority of physicians would say in the old days, let's say 20, 25 years ago, right? You have metastatic non-small cell lung cancer and the prognosis is such and such. I actually decided early on in my career never to say that. So if people come to our clinic, we actually don't discuss prognosis. We discuss, and you know, at stage 4 is different for every person, right? Mm-hmm. Stage 4 could be sometimes just in the lung. Stage 4 could be lung or liver or brain and so forth. Mm-hmm. So those are all different. And I've actually had these discussions many times, and what I actually say, a lot of people then start talking about death and dying. So I actually have always said I don't believe in death and dying, I believe in life and living. And that's an important way of us thinking about this, right? Because here you are, 2007, diagnosed with lung cancer, quote unquote, and then at the same time, now disease-free. Mm-hmm. But all these emotional turmoil that you have to go through, I can also tell you your healthcare providers go through the same thing. Mm-hmm. You know, it's very important because we worry about you. We want to make sure you have a great, healthy life. You live a long life. At the same time, you don't have toxicity. So let's come back to this, you know, and I start thinking about, well, how does somebody like you, Elizabeth, get lung cancer, but then how do you battle this lung cancer? How do you defeat it, right? Mm-hmm. So you said you had molecular testing and that was negative.
Yeah,
what does that mean? So wild type for what?
Well, it was very early on, and actually I had it, I hope you don't mind if I mention the companies that did the test at that time. Is that okay? The first company was Response Genetics, but it was very early on. I think they were only testing for about 7 markers at that time. So I didn't show positive for any one of those. They use FISH testing for that, which is different from another company that did the second one for me. So they identified me as being wild type because I didn't have any of those, I don't want to say mutations because they aren't all mutations, but they're markers.
Genetic alterations.
Genetic alterations, right, I guess is the best way to put it. So, but fortunately, my oncologist at the time, Dr. David Gandera, had a personal experience with treating people with my disease. He said basically at that point we kind of called it bronchoalveolar carcinoma. And so he was the one that suggested participating in clinical trials, and I've always been an advocate of that because I was in biotech, and how better do you find out about new drugs than having people participate in gaining the information from clinical trials. So when I progressed off from more traditional, the triad of treatment that I was having that included general chemotherapy, he said, I want to try a Hail Mary. He says, I think you'll respond. He says, I want to try a kind of a unique combination of Tarceva and Alimta. Mm-hmm. And I responded, we hit it out of the park. I had, again, no evidence of disease, which doesn't mean that I'm cancer-free. It's simply the way I think about it that kind of helps me deal with this and live with this disease is that they simply can't see my cancer, and it isn't active, but it's still there. And so this concept, and like what Bonnie is trying to get to with so many patients, is that you may not be cured of cancer, but you're treating it like a chronic disease, like AIDS, for instance, so that it takes a while to get to that point where you can get your mind around it and come to live with the trite saying of new normal. But you can get on with your life when you're on a treatment that is more targeted and actively fighting your cancer versus decimating everything in your body. You know, your quality of life is so compromised.
Right, and this pemetrexed and the erlotinib you were on was very well tolerated for you, and this is... Yeah,
there were some issues. There were some toxicities with it, and actually in most of the treatments that I've had, I have to reduce my dosage because I'm sensitive to the drugs, even with the crizotinib I'm on right now. I'm on a reduced dosage, but
Okay.
it works very well.
Yeah. So, you know, for example, for pemetrexed, we worry about kidney function, right? We worry about
Right.
other organ function.
Right.
You always get those B12 shots because it was initially at the University of Chicago, it was Dr. Vogelsang who identified that patients who were getting pemetrexed were depleting themselves of B12 and folic acid. That's where it came from. So you're exactly right. Clinical trials helped us prove those things. And it's very nice that Dr. Candera was able to come up with an innovation. But that's what's important, right? You need a physician, you need your team to be experts at this. I think as we think about lung cancer, you always want to be able to find those lung cancer experts.
Right.
I think it's okay. We all treat lung cancer, we all treat breast cancer, we all treat colon cancer and so forth. But if you have expert opinion as well, even for one time only, that's actually very important.
Right.
And we tend to emphasize that to all of our patients. And what's also important, Dr. Gendera is a thought leader and a world-class leader, right? But he also reaches out to others to be able to say, well, what about this? What about that? I do the same. And it's very important to build that sense of community so that patient care is taken care of.
Right.
So then you said about 2 years ago, you had all this, and then you had repeat testing. What happened?
Well, I progressed, and also, as you said, one of the drugs started causing problems with my kidney function, so now I'm a little bit more compromised with that. So the treatments aren't without their downsides because they definitely take their toll on your body's health. So, and that was one of the reasons why I think we had to reduce my dosage, and I may have started to progress. But at that point, we actually did a biopsy. I'm trying to think, did we do a biopsy before or after? Actually, we did a core needle biopsy after, but what we also did at the same time was that we accessed my original tumor tissue, which was still at the original institution that I had my original surgery done, and we sent that off to have comprehensive genomic testing. And that does a much larger of hundreds of different types of translocation, genetic analysis.
And this was next generation sequencing?
Right,
is that
exactly.
What it was, the NGS?
It's not as deep from what I understand with the with the fish, but it gives you a broader perspective. It looks at different things. And so that had identified that I had the ROS1. And Dr. Gandera was quite surprised because I was on the Tarceva for so long, and he thought that that was what was working. But in hindsight, he says it could have been the Alimta that had worked. Right. But anyway, he decided he wanted to have the response genetic testing done in addition to that one to validate that it was indeed ROS1. And we found out that I was 73%
of the nuclei were positive.
Right, and anything over 15% is considered positive, so I was extremely positive for the ROS1. So obviously that told us that crizotinib was, the obvious choice for this. And as you were saying, I think being in biotech and growing up in a medical background, I really focused on trying to find a physician that had personal experience and in treating my particular type of cancer. I realized that having a general oncologist just doesn't work, especially with a disease as complex as lung cancer. There's just so much knowledge that they need to gain in order to have that. And going to someone like yourself or Dr. Gandera just makes complete sense to me because they're familiar with it. You're willing to take a little bit more risk because you're not relying on standard of care. You're understanding the positives and negatives and all the nuances like you were talking about. Fractal is a perfect example of this. I mean, there's all these permutations, and unless you're doing this all the time, you just don't have the knowledge to be able to give the patient the best possible treatment.
Yeah, and what we absolutely, Dr. Gandera was right, and you were right to send it to the next-gen sequencing. We do the same, and we preach the same, so to speak. And you identify this. Can you do that by just next-gen sequencing, or do you have to do FISH analysis, or do you have to do CISH analysis, or even immunohistochemical analysis? Those are all important questions, and not everyone knows even that these tests exist, and not everyone knows how to interpret these tests.
That's exactly right.
So we actually are strong believers in education. And so just like what we're doing today, we do that repeatedly throughout the community, throughout the world, through all of the conferences we have or discussions or even our fellows and residents and so forth. We teach them that this is how we should think about them. But we should also make it a standard of care.
Yes,
And this
absolutely.
This is what
I would, please, insurance companies, if you're listening, please.
Yeah.
It makes it, I mean, seriously, I would not be here today if I hadn't have gone to Dr. Gandera and he decided to do something based on his personal experience, but we also were always validating when we could with further information such as this type of testing, because more information is always better. Even if initially if it was wild type, we knew what it wasn't. And so we could narrow down what the possible treatments that might be more effective for me. And it really, it's that sort of thing, because with most cancers especially, most of the time it's not black and white, it's gray, and you need to have an educated person even looking at the results from this test and saying, does this really make sense?
Exactly.
Especially with what the patient is presenting. So you definitely need to be in the hands of someone that really knows what they're doing.
Yeah. And testing is important, but I also say the following in the clinic room, right? Is if we get a PET scan, and many patients get PET scans repeatedly, that's over $5,000 or $6,000 each PET scan, and yet it's approved by the payers, right? But then if a next-gen sequencing is, let's say, about $5,000 to $6,000, but it yields so much information that saves your life, that should be part of our equation, right?
Absolutely.
And that's what we're fighting for. We are absolutely fighting for that. And then where do you go? Do you go do this at Response Genetics? Do you do that at Caris? Do you do that at Foundation One? Do you do that at the Mass General? Do you do it at UC Davis? Do you do it at City of Hope? I think those are all important questions. And at the end of the day, what I have to say is we all have to come together and define this. And those, who are the people who come together? Those who are the experts and also the patients. So ROS1, right? We take care of a lot of ROS1 translocated patients, and we were the ones who helped discover this for crizotinib as well, and we had that New England Journal of Medicine paper. So I think back to back, we're thinking about ALK, we're thinking about ROS1, we're thinking about MET, we're thinking about EGFR. But I don't take that credit singly. I just say, as a team, we all did this.
Absolutely.
Right? I mentioned Dr. Wu, for example. There's Dr. Shaw. There's Dr. Iafredi, Dr. Gandera, Dr. Kelly, all of these physicians. But I'm not throwing out names just to say the names, but to be able to say, I think what we're realizing that is individually you can't solve the problem.
It has to be a collaboration.
It has to be a collaboration. But as a collaboration, we also have to fight the system, right?
Absolutely.
And what is the system? The system could very well be, can you be seen in a timely fashion in the clinic? Exactly. Is the system, can you be seen by an expert? If you can't be seen by the expert, can you do telemedicine, as an example? And if you can't do telemedicine, are there other venues? Can you do email? Can you do, I actually love FaceTime. So people can actually, a lot of people want to know what I think about certain things. We FaceTime and we look at the scans together. This technology is just absolutely brilliant. But at the same time, you have to be aware that these kinds of technologies exist. Molecular diagnostics, the therapeutics, the multidisciplinary team. So since you started the crizotinib, you said you've experienced some side effects. Is your vision a little bit different? Are you having nausea?
I'm going to I'm going to have a colonoscopy because the intestinal issues have been swinging more. It's more of an issue. I've had edema. I do have visual disturbances from time to time, especially sometimes at night or if something's bright. I have light sensitivity of things and things like that. But the visual, you kind of get used to it, and I just wear my sunglasses a lot more. So they're kind of practical things that you start to do, but it's a matter of, again, trying to optimize the quality of your life and trying to figure out what I can do as a patient without taking drugs, because so many times, especially with me, since I tend to be so sensitive to them, invariably when I take a drug for one thing, I might get a side effect causing something else. And so if there are other ways that I can manage these things through non-pharmacological approaches, so much the better, because I don't want it to interfere with my chemotherapy and also affect, my kidneys or some other things that might be a little bit more sensitive now that I've gone through a number of courses of different treatments.
And that's where, some of our patients do say sometimes they have a hard time driving at night because of this visual alteration that can occur with crizotinib. So you do have to alter your quality of life or your functioning based on the quality of life. But we do also say, like my dad used to say, my dad was a pathologist, and he would say, if you have arthritis, don't bang your hand against the wall, right? So you do the same thing. If you have night blindness, don't drive at night.
Right.
But at the same time, can we correct it? That's what I look for. How can we correct toxicities? And so we have to be very sensitive. But you also need to keep a good track record of how you're feeling with all these therapies. The way we figured out how patients got very fatigued or had severe nausea and vomiting is by talking to patients, but then they also kept a great log of what was going on. So what I also do in our clinics and our whole team does, and actually majority of people, is we empower our patients to keep a track of everything. And then sometimes you don't get enough time in the room, right? But then you tell the nurses what's going on, and the nurses come back and say, this is very funny. Why is Elizabeth having this, or why is Elizabeth having that? So it's really that team approach, and we're part of your team, right? So that means your physician, your nurse practitioner, your PA, your nurses, your CRAs, and so forth. But then everybody pays attention. But I think if we all paid attention, we can do less toxicity.
Right.
Or manage toxicity.
And I think as a patient too, I think the patient also has a role there, because I'm now more aware of what works for my body. For instance, you talked about fatigue, and when I was on the Alimta that we were doing the B12 shots, I continue to have the B12 shots to this day, because even though my B levels are within the normal range, I definitely notice a difference that they help me. And about every quarter, when my tail feathers are dragging a bit, I get the B12 shot, and it works beautifully. So it helps me. It may work for some people and not others, but I can also help my medical team by sharing with them of trying things. I'll try this and that, and say, you know what, consistently these things seem to work. And there have been a number of times that I've gone into the nurse practitioner or talked to Dr. Gandera and said, I really tried this and this seemed to work. Or when I was on Tarceva, you said, I'm really surprised that your fingers, you don't really seem to have the cracking with your fingers and things like that. What are you doing? And I had a special cream that I was using that I used to use on horses' hooves, believe it or not, and it worked tremendously well. Just things like that, where there can be a very mutually beneficial relationship between the patient and the doctor, because the patient is living with this every single day, day to day, and they're the ones that are having to manage the side effects, because unfortunately, as well-intentioned as the oncologist is, like you say, you may only have 15 minutes with them, and you're really focused on getting my cancer and killing my cancer, and that's what I want you to do. And I look to my pulmonologist, my GP, my other specialists maybe to help me manage the side effects or the quality of my life. And then if I'm learning something there, I can kind of share it with the oncologist.
Absolutely. And then symptom management is important. Palliative care is important. And so all of the healthcare providers are incredibly important. But what I also think is important is support groups, right? Where you share amongst ourselves, and to be able to say, well, I had this and this and this, and I'm on this dose, and and I tried this. And we strongly believe in that. We bring together support groups to be able to say, can we talk about these issues? And nutrition is very important, right? Exercise is very important. The mind-body is incredibly important. And so how you feel about what you're doing, and are you depressed? Can we think about depression? So all of these things are important to you And it's important for us to be able to help you get through that. And a lot of times, it doesn't happen overnight. You know, nothing happens overnight except for traffic in LA. And, right? And so the big thing we worry about is their long-term toxicity, short-term toxicity. How is the person feeling? What is the quality of life? But we take, for me, I'm always worried about, you know, the molecular alterations that can occur. What is the cancer? What is the stage? But we also have great teams that we worked with together that we worry about the whole person. I think that's actually important, and I commend you for everything you're doing, and you know, God bless you.
Thank you.
Yeah.
Well, you know, what sure beats the alternative, as my dad would always say. And,
Exactly.
And I want to optimize the time that I have left. Something I wanted to mention to you, and it's a shout out to Bonnie because the Darrow Foundation has done tremendous things, is that you mentioned support groups. And I'd gone to some support groups before through hospitals, and it was like, kind of depressing, not really, you know, a lot of beneficial information. And then I found out about the Bonnie J. Darrow Lung Cancer Foundation. And they have something called the Living Room that they have once a month. And it is a wonderful forum for patients to either to sit in on personally or listen to on the web. And there are a number of patients that participate and share and have specialists like yourself speak. It's probably been one of the most productive learning experiences that I've gained, where I can share information and also learn from others. And I've had people literally come up to me and say, or email me and say, you mentioned such and such. I had been dealing with it and I didn't know how to deal with it. And you had a great suggestion. Or if I find out somebody who has ROS1 and I can talk to them, having that ability to be able to talk to other patients, albeit anecdotal information and it's not medically proven, having that anecdotal information is absolutely invaluable. Not only realizing that, you know, you're able to live with this, but also improve your quality of life.
I think one huge goal for our country and our whole world should be we collect all that information and utilize that information to help others. And I think we should do that. We should talk to the NCI even more.
Yes, absolutely. I agree.
Okay.
Thank you
Great.
so
Thank
much.
you.
I really
Lovely.
appreciate your time.
Appreciate it. Okay. Nice to talk to you.
Nice talking to you
Okay.
too.
All right.
I'm going to sneak up behind you, Dr. Salguia. We've got some patients in the audience and some online that have some questions.
Great.
If that's
Please.
okay.
Yes, definitely.
So I'm going to start with an online question, and it's actually from a retired physician who has lung cancer. And the question is specific to the CXCR2 inhibition. Is it related to genetic mutations?
Okay.
Oh, you're mic'd. This is
Oh, I'm mic'd already.
This one's mine.
Okay, sorry. So that's a very specific question. So it turns out there are, you remember the number one I was talking about in that cancer cell, there are these cell surface receptors. And these cell surface receptors can be receptor tyrosine kinases that have a tyrosine kinase domain, or they can be integrins, which are important for adhesion. But you can also have chemokine receptors. So chemokines were initially discovered in hematopoietic cells, where they found, you know, how do blood cells traffic themselves. And then ultimately, it was discovered that even HIV T-tropic virus uses CXCR4 as the binding site to really cause HIV internalization. So all these chemokines, CXCR1, CXCR2, CXCR4, are important in terms of certain malignancies. Majority of times they've been shown, for example, in leukemias. Certain CXCR4s have been shown, and we've actually worked a lot on that for a long time. And I'm glad you asked that question, and maybe you didn't want this answer. But the CXCR4 or CXCR chemokine receptors are quite important to drive chemotaxis. So they could be important in the progression of the tumor or metastasis of the tumor potentially. But are there potential inhibitors? So the most commonly studied has been actually CXCR4, not as much CXCR2, and especially for lung cancer. So CXCR4, its ligand is CXCL12, which is known as STF1 alpha, and there are certain therapeutics that have been used. We haven't been that happy with them, but it may very well turn out that these receptors or these chemokine receptors may need other targeting molecules as well. So it turns out, for example, the CXCR2 or CXCR4 may have to synergize with other receptor tyrosine kinases like KIT and MET. So is there a gain of function if you have a CXCR2 mutation? It's a potential possibility, but the therapeutics haven't really been developed yet. But I think that's something we should study even more. And all these chemokine receptors and their ligands have a role in lung cancer, be it non-small cell lung cancer and small cell lung cancer. But that hasn't been studied as well as, for example, MET has or ALK has or RS1 has.
Thank you. So Andrea is online taking questions, so anybody online who has questions, please type them in now. I know Enrique in the audience had a question. I don't know if he has a mic or if you want to just come on up and join me.
Yeah.
That's fine.
You come up here, yeah.
Have him sit in the chair.
Hi.
Yeah, I'm
You
going to
sit
hand
up
you my
here.
mic.
Have a seat.
Thank you.
How are you?
Hi, how are you?
Nice to meet you.
Enrique Martinez.
Hi. Nice to meet you.
Nice to meet you. I am Enrique Martinez. As I said, I was diagnosed 2 years ago. I was diagnosed with androcarcinoma 2 years ago. In the beginning, I was through the chemo for almost a year, 21 rounds of chemo, most of them with Alimta. And then during the first year in 2014, July, I got a biopsy, and I got the ALK positive. So at the end, when the chemo stopped working, the doctor switched to the pills. Because I did a positive, I got through. The first one I went through is crizotinib Alcori.
Crizotinib.
Crizotinib, yes. And I was since March that last year, so it's almost 11 months for now. And I was in the stable disease for almost since I started. So the last scan I did was a week ago, and there is a little progress. So I don't know exactly how much the progress was, but the doctor said that now I have to switch to a new treatment. So the new treatment will be the
Ceritinib?
Yes, ceritinib. So I just waiting probably a couple of days to start, because they request on the pharmacy that is taking for a while to arrive. So he asked me to continue taking the Halcori until the new medicine, and then stop and switching to the new one. So my question is, I am the right track to go to the new one? Great. This is the first question. Another question that I write was, you mentioned about the biopsy. I just get the biopsy more than a year ago. It's almost 18 months, I'm sorry. So now that there is some progress in my cancer and my tumor, so I need to get another biopsy?
Great question, Enrique, and thank you for coming today. It's very important that you got diagnosed properly. You know, you had adenocarcinoma, you had the ALK translocation, and I'm assuming it's the EML4 ALK, and that's the most standard one. And it does respond to crizotinib, but then you do progress from it. So one of the key questions, and I'm not your physician, and I'm happy to talk to your physician if you'd like, and happy to give you my cell phone number, and they can call me immediately.
Perfect.
I actually give out my cell phone like there's no tomorrow. I learned that from my kids, right? What's that? Yeah, okay, so it's up to you. But the big thing is we really have to look at your scan and then decide where is the progression and how is the progression. Sometimes the progression is only in one site, so every once in a while what we do is to do radiation and continue the crizotinib. Sometimes it's a florid progression and then you have to go on to another therapy. If it's an easy biopsy, we usually do recommend it, but if it's a harder one, then at the same time you already have a second-line therapy, that's the ceritinib. And so, crizotinib is tolerated okay. We just heard Elizabeth, she had some side effects, as you know, in terms of the nausea or the GI disturbance, as well as the visual problem. Ceritinib has a different sets of toxicity. A lot of times you do get nausea and you have to take it without food, and it's at 750 milligrams, and sometimes you have to reduce it. So it does become an important issue. So are you being considered for the right medication? That is the standard of care now. That is, if you've progressed from crizotinib, then you should consider ceritinib. Now, with respect to you specifically, what I would like to know is, where is the burden of the tumor? Like, what does the CAT scan show? And how large is the tumor burden? And if it's just a solitary site of increasing versus a multiple site of increasing. So I think those are questions you should ask. And I always empower, like I said, I always empower our patients, write down those questions and ask your doctor. But at the same time, your doctor should be able to discuss that with you. But if they need more expert advice, then we're available anytime.
Okay.
Advice is for free. But I also caution us, right? It depends on what does the scan look like. The other thing is, should you use a CAT scan or should you use a PET scan?
Yeah, this is another question I wanted to ask.
I asked that first.
Oh, yeah. I did CT scan. It is necessary to get a PET scan. I never get one.
Not necessarily. So one of the things, for example, what we didn't talk with Elizabeth about is how did she get scanned? Did she get CAT scans? Did she get PET scan? So the old definition of the type of tumor she has, sometimes it's not picked up by a PET scan. These old bronchial alveolar cell carcinoma, which is now in the subcategory of adenocarcinoma, PET scan is not the greatest thing, so you have to do CAT scans, right? And so in your case, if your doctor's been following you with CAT scans, I think that's very reasonable. If there are questions about the growth of the lesion or the tumor burden, one could consider PET scan. I don't like to do MRIs. I don't think MRIs are there, especially for the lung. For the brain, absolutely yes. Maybe for the liver, but CAT scan for the lung is very appropriate. PET scan, remember, shows you activity of the tumor, but it doesn't show you the size of the tumor. Sometimes they do what's called a fused CAT scan and PET scan, but that's a different issue. So my biggest advice to you is write down those questions we just asked, that I just asked you, ask your doctor, and then if there are any other questions, call me, call other doctors who are experts in ALK positivity, and we're very happy to help. Okay? God bless you, Enrique. All right. Okay. All right. You're welcome. Okay.
So you want me to sit down?
Yeah, go ahead.
Oh, okay. I wasn't planning on this, but.
Okay.
So there's a couple of other questions from
All
online. One is, how much progress is being done in lung cancer that has metastasized to the brain? We know that's a challenge.
Yeah, a lot of it. We actually just published a paper 2 days ago. And so, lung cancer is a very unique cancer. It can metastasize almost anywhere. One of the other things that we tend to appreciate is there's a differential effect of metastasis based on what translocations or what genetic alterations are. In the old days, when I was a fellow, and I was a fellow at the Farber in 1990, we would just say, okay, you have small cell lung cancer, it's metastasized to the brain, this is what we can do, and that's it. Then non-small cell lung cancer metastasizes this way. So in 2003, we published a paper that was quite innovative. I was actually getting tired of not doing anything for brain metastasis. We would see a great amount of patients who would have recurrent brain metastasis, but then what would happen is that you couldn't give them anything. So then we thought about combination of chemotherapeutics, and such as, let's say, for small cell lung cancer, etoposide and temozolomide. We published that in the Oncologist in 2003 based on our preclinical and clinical experience, and it actually worked dramatically. Then we did it for gemcitabine with temozolomide, and that was another case that we published at that point. But then not too much went on. But then ultimately, what we realized over the past 5 to 7 years is that, as an example, we're seeing more brain metastases. For example, as patients live longer with ALK translocations or with ROS1 translocation or with other genetic alterations. But even for patients, for example, with ALK translocations, we've seen young women with severe abdominal pain who ended up having ovarian metastases or uterine metastases. Unheard of precedents, right? I've been practicing for such a long time. I rarely see ovarian metastasis from lung cancer or even gastric metastasis. So we actually just published that last year too. So brain metastasis, we're paying a huge amount of attention to now. So not only do you worry about brain metastasis, but you worry about leptomeningeal metastasis, right? That's through what's in the leptomeninges. So there are certain drugs that can penetrate. So as an example, and you know, Enrique, we talked about ceritinib. Ceritinib has a great brain penetration, so it can do a lot of things. So it's very nice to now know that we are paying a lot of attention to brain metastasis. What we haven't done, we're paying attention to that clinically. We're gathering all the information. We're trying to make sure that we can come up with innovation, and I'm happy to provide those articles that we've just published actually on this. But at the same time, what we're not doing is preclinical studies. Are we developing models in the laboratory to be able to study this faster? And that's something that we need to pay attention to.
So I actually have, there's some more online questions, but to tag along to what you're talking about, sort of two questions. One, when we're talking about standards of care and brain MRIs as they relate to a lung cancer diagnosis, is there a particular, I hear all too often of patients who've been diagnosed, it really doesn't even matter what stage, but obviously most of them are in later stages, who have never had a brain MRI. So at what point is it a stage one? Is it any patient?
So those are challenging issues, right? You have guidelines. So let's say you have NCCN guidelines, and in those guidelines you're suggested for stage 1 not necessarily to do it. Then stage 2 or 3 you might do it. Then stage 4 you have to do it. And then you develop guidelines within your own institution. So for example, we have standard operating procedure within our institution because City of Hope, as an example, is you know, the Duarte campus, but then there are 13 other ancillary sites at the University of Chicago. So we all come together to develop those guidelines. But guidelines are what they are. They're not like laws that have come down from Moses, right? They're not like those laws that we follow to. I personally believe it's precision medicine and radiology, meaning you have to individualize it according to the person. But where it becomes challenging, right? You could get a PET scan every day. You can get an MRI every day. But it is, for example, for PET scan or CT scans, it is radiation, right, that you have to worry about over long term. So what we have done and what we should do as a nation and internationally is to develop these guidelines and or laws that are really tailored to the individual patients. We do that in our practice. Every thoracic, a great thoracic oncology community that I know do that by practice. But can I give you words of wisdom? Well, we should do this every 3 months versus every 6 months versus every 6 weeks. No, because for us, we make our decision based on the person. Suppose somebody had diffuse miliary pattern in the brain and they had brain metastasis, they got radiation therapy with whole brain radiation. I might do their scans much sooner versus somebody who had a solitary lesion, who had a surgical resection, doing great, and is now 5 years out, right? So it really, all of these scans and what type we're doing for follow-ups really depends on the person.
So when you talk about, I'm going to stay on brain radiation for a second, and then I'm going to move on to these other questions just because we have some time. When we're talking about whole brain radiation versus either a gamma or a cyber, you know, how many lesions is too many? How many? I know, again, you're probably going to be at precision medicine. It depends on the person. But how do you, is that what your answer is going to be?
You already answered my answer. Yeah, right?
Okay.
I don't believe in giving general blanketed answers.
Okay.
I think we should do away from that. I also, in my clinic, don't believe in giving out statistics. In my mind, so as you now know, I used to be a mathematician, right? Statistics can convert a pretzel into a straight line. And so be careful as to the statistics you hear, be careful as to the statistics you read about. And I think the only statistic that counts is really what's going on with you. And so is whole brain important versus stereotactic important versus a surgical resection followed by radiation? And we actually talk about that in our papers in terms of therapeutic decision making. And again, that's not very easily simplified.
Right.
And you really have to have that whole multidisciplinary. So in our center, as an example, right, you have to have a neuro-oncologist. You have to have a radiation oncologist who's like a brain specialist. You have to have a neurosurgeon. You have to have a thoracic oncologist like myself who's really vested in taking care of our patients, and then make that decision. I think gone are those days where, oh, you have brain mets, let's go to whole brain radiation. I don't think you should do that. I think you say you have brain mets and we should really talk about you and then make the right decision.
Perfect. Love that answer. So the next question from online is considering or looking at metastases to the bone. Is there, a way that is handled, better than others, whether it's systemically or with radiation therapy?
Yeah, again, it depends on where the bone metastasis is and what is the tumor burden. Some of the things, let me bring up some caveats from our own clinical experience. So suppose that exon 19 deletion example I gave, and then they only had bony metastases. And then they progressed in their bones with respect to the bony metastasis. How do you know, what are you going to biopsy, and how do you know there's a T790M mutation, right? And so we were quite surprised and happy is that for the patients such as bony metastasis and you can't biopsy, you can actually do a liquid biopsy. And we were able to identify, for example, T790M, and we have that paper that's gone out and so forth. So that's one way of thinking about biopsies of bone. Second thing is, can these bisphosphonates or even denosumab help bony metastasis? And I believe so. There's enough data to be able to say that zoledronic acid or denosumab does help, and then there could be synergism of that with chemotherapeutics, at least for lung cancer. I think denosumab and its role in breast cancer is being debated heavily at this moment in time, but we'll find out what those results are over the next few years as well. Do chemotherapeutics help? Do targeted therapeutics help for bony metastasis? Yes. But you can also have a flare response. So what can happen sometimes, you get a CAT scan and all of a sudden the report says, oh, you have a sclerotic bony lesion at the T5. And then at 6 weeks ago or 8 weeks ago, you didn't have that. So what is going on there? That's where you have to be very cautious. A sclerotic response in the bone could represent a healing response that you weren't able to detect by your technology. So you really have to, again, review it very carefully. And my biggest advice also is any patient who has scans, the physician should look at the scans, not just the reports. The reports can be quite nebulous at times, and you really have to talk to the person who read the scans. You have to really look at the scans as well. And like I was telling you, my trick that I do now, a lot of times we get consultations, but the consultations, sometimes the person doesn't bring their CT scans or their CDs because they got upheld in radiology. So what I do is I actually personally call the physician and I FaceTime them, and then on their PACS system we can see the scans together. So it is so crucial to be able to review that. And bony metastases are very tricky, not a simple answer. And we learned that because of breast cancer in our prostate cancer world, and we're applying that for lung cancer, but it is different.
Okay, next question from online is, do general oncologists have a better way to navigate clinicaltrials.gov to be more helpful in helping to counsel their patients on what trials might be good for them?
Sure, call us.
There you go. It's cell phone number available, right?
Exactly. It's a very, very challenging issue, right? It's very difficult to suppose, again, if one has EGFR mutation, then developed T790M with the MET amplification now, what clinical trial? That's a very tough field to navigate in the websites. We helped develop that web app that I talked about a little bit earlier as well, that mobile application. But there will be a lot more tools that are available, but they're never perfect. So the best way I say is make friends with the experts.
Right.
And then phone a friend.
So I think
Yeah.
on that note, I think one of the things that's important, and one of the types of patients that we work with, globally, don't actually have that benefit. They're in more rural parts of the country or parts of the world, and I just want to point out that it's you coming here and sitting and talking about these different topics and giving your expert advice is very helpful, especially to those people who don't have access to it.
So I'll tell you the trick my father did, right? My father was a pathologist. I'm convinced he knew everybody in India. And I'm convinced he knew every Indian physician in the U.S., right? And they would just call him and they would say, blah, 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 and I have this person with lung cancer, what do you think? Immediately he would give my phone number.
Perfect.
Or he would give my email to somebody in India, be it rural India, and then we take pride in the fact that we're available globally. And so we would respond. And one of the things and precaution I take is a lot of times you get emails and you don't understand what the email you got, and a preposition can throw you off. And then if I respond back by email, so what I actually always say is, why don't we just Skype? Why don't we do FaceTime? Why don't we just talk about what is going on? Can I see the scan? For me, it's so important to see the scans, right? Can I see the molecular report? The molecular report from Caris is different than the one from Foundation. Mm-hmm. And it really takes a lot of time to navigate. And what you're doing, especially from the Adario Foundation, right? We should be available to everyone globally. How do we do that? I don't know, but we need to do it.
But basically what you're saying is today there's no excuse. With technology being what it is, whether it's a FaceTime or a Skype or we should be able to figure it out.
Exactly.
Right.
And we have a large connection now with China as an example. So City of Hope has established itself with China, and we are doing this. We are going to be doing that. And we need to do that more and more and more. And we, quote unquote, the experts should be available. We're still allowed to sleep, but
Right.
at the same time, we should be available to answer questions.
That's great. So another question from online is specific to Opdivo, but I'm assuming it could be any immunotherapy that may be out there. Claims significant improvement in length of life, small print, 6 to 9 months. Is that fair advertising, in your opinion?
That's a loaded question. Like what I started by saying, I don't believe in statistics. I believe in individualizing, and I'm going to stick to that. What do the advertisers do? What does, let's say, BMS do versus what does Merck do? I think that's their business. What do I do with my patients, with the door closed, seeing the person and talking about that? And like I said, I usually don't discuss statistics. I discuss what are the potential options, what are the potential benefits, and at the same time, my decision making is really dependent on how the person responded.
You are singing our song, and I see heads nodding all around the room, and I'm sure folks online, their heads are nodding too. One of the questions that I think might have come in before Dr. Salgia actually answered it, but it was referring back to bone metastases and being really careful about what you're looking at. Is it some sort of healing or calcification versus an actual metastasis? So that was answered. So if whoever... It was, okay.
Okay.
Does anybody else in the room have any questions before we say our thank yous and give big applause? And no? No? Everybody knows everything there is to know about precision medicine. We're all good.
Oh, go ahead.
Yeah, Athena.
Is there an easy way to explain how Tarceva or erlotinib works? I just have this feeling that it dries things up because my whole body's all dried up, but it's dried up some of my tumors.
Yeah.
But does it work like that, or?
It does. So it's all about toxicity, right? So let me step back a little bit. How do chemotherapeutics work? Chemotherapies work in cells that are dividing fast, right? So the traditional chemotherapy, let's say paclitaxel, or let's say docetaxel, the way they work is they target the cancer cells because they're dividing very fast, and then they kill them. But then they also go after the dividing cells in the body, right? So what are those fast dividing cells in the body? Those are your bone marrow cells, right? So chemotherapies, as an example, will cause low blood counts, right? So it can cause anemia, low red blood cell count. It can cause low white blood cell count, right? When somebody who's gotten chemotherapy, we always tell them, well, you can become neutropenic. What that means is that the white cell counts are coming down and that you can get an infection. But chemotherapy is attacked it because they're the fastest dividing cells in our body. So erlotinib or gefitinib or afatinib work in a similar fashion. They are, in some sense, chemotherapeutics. They're targeting the EGFR receptor on the cancer cells. So they will kill off the cancer cells, but guess what? You have skin cells which have EGFR receptors too, and that's why you get a rash. And the same thing happens with the dry mouth. So this is really toxicity that's really expected because of based on the EGFR, but there are some toxicities that are unexpected. Such as, for example, interstitial lung disease that can happen a little bit more in the Asian population, and we can't explain that.
Thank you very much.
Anybody else? No, no, no. Online, are we good?
Besides, everybody wants his phone number.
Okay, with that, I want to thank everybody for coming out tonight. I want to thank prIME Oncology for this opportunity to bring sort of a unique perspective to the continuing medical education space. All of our sponsors for supporting it. I'm beyond thrilled that you came out and helped us out with this, and I look forward to seeing the end result and to, of course, working with you all the way until we get this done.
Yes.
Right? Yeah. And don't forget to get Dr. Selgia's phone number on your way out. Don't leave here.
Oh yeah, anyone can have it
without
anytime.
first grabbing
Not a
the cell.
problem.
Thank you, everybody.
Thank you. Okay. I appreciate that.